tonight's topic is looking at some tips for needle guidance. So as we get started, I want to welcome everybody along and also to just acknowledge our sponsors who have been very supportive in our efforts to bring the Coaching Corner to you once a week. So thanks again to Philips for providing the machines, but also for supporting the Coaching Corner. So tonight's topic is tips for ultrasound guided needle placement. In my mind, it's kind of, once you understand how to guide the needle, it doesn't matter what the target is. The principles of needle guidance are the same, whether you're going into a breast lesion, into a vessel, or amniocentesis. The technique for guiding the needle is the same regardless of the target. Of course, the procedural considerations you need to take into account are very different for all those procedures. But once you've mastered the technique, I think you can get a needle wherever you want it to go, really. So, and I'm focusing tonight more on what are some of the problems you encounter and why. And I've kind of, in looking at all the different ones, boiled it down to about 3 different categories of problems that occur because because people have either not prepared or have, I'm sorry about this, I'm just trying to admit somebody else was sitting here. No, all good. So the 3 different categories are inadequate preparation, next one's inappropriate setup, and last but not least is getting the alignment wrong or missing your target because you haven't got everything lined up. And I think this is the one that people struggle with the most. And once you nail it, then everything becomes easy. So why even bother do ultrasound guided procedures? It's well documented, whether you're talking emergency literature or in the general medicine literature. There's heaps of, even anesthetics, there's heaps of evidence out there to demonstrate that it increases the safety of the procedure, it increases success rates and decreases complications. So whether it's, ultrasound guided anesthesia for something, and it means that you're using less injectate and getting a more effective block, whether it's making sure that you get your needle into the right target vessel, there's heaps of evidence to show that it increases safety and decreases complications. When we're looking at vascular access in particular, we're aiming to get the first attempt as the best attempt. You don't want to go and have to try getting vascular access umpteen dozen times. So anyone that's had a history of difficult access before, and your patients say, geez, they always find it hard to find my veins. If you've got extremely elderly patients or overweight or underweight patients, anyone with chronic disease who's dehydrated, your IV drug users, if they've got any signs of limb swelling or scarring, or even if you just can't see or feel the vessel, that's a good time to pull out the ultrasound machine and guide your entry. So let's look at the preparation. So before we get stuck into the procedure, it's all about getting everything ready and knowing what you're dealing with. So figuring out which vessel's which and where the dangers lurk. If I'm going for that vessel, am I going to go through a nerve? I don't want to accidentally injure something along the way. Or if I'm going for that abscess, I don't want to put my needle through a vessel on the way. So it's figuring out what's around, figuring out if your veins are patent, what's the diameter, what's the gauge of your cannulas you should be using, how long your needle is, all those sorts of things can be sorted out in a good scout scan. So we'll start with the 3 P's in preparation. It's picking the right probe for the job. So if you are fortunate enough to have more than one linear probe, you want to choose the one that the footprint best suits the job. So, if you're doing a little neonate, you don't want to use the 50 centimetre wide footprint probe because it just doesn't fit. Neonates have got a much shallower depth, so a higher frequency small footprint probe is going to be much more appropriate. If you're looking for a deeper target, it might be that you want the lower frequency linear, and in some cases that might even mean using the curve probe. You want to make sure your patient is set up properly. So a number of things here so that they're comfortable, so that the position that they're in actually helps you rather than hinders your procedure. So, you know, if we're doing a PICC line, making sure that the arm's out nice and straight and that you can line yourself up and the needle and everything coming in straight rather than coming in at all different crooked angles. If your patient's comfortable, the chances are they're going to be able to sit still a bit easier for you as well. And then choosing the right preset. So, you know, if we are looking at peripheral vascular access, choosing the venous setting, and that just sets our depth parameters, focus parameters, and the Doppler settings so that it's optimized for the body part that you're looking at. Once you've got all that set, you need to optimize the image. So here's just a couple of examples. On the left, we've got the depth set. I mean, it'll work, but we can decrease the depth here on the left-hand side. And I've done that here. And I just want to point out, this is the radial artery here with the veins and a big sort of superficial vessel there. So if we decrease the depth settings, and that will also adjust our focus settings, but it also just makes those targets bigger on the screen that make it easier for us to get a needle into. You can use the color Doppler to help you figure out which vein's which, or which vessel, I should say, is which, rather than just artery vein. Sometimes you might even see an example where you've got B mode flow. So in this example, the blood's flowing quite slowly in this patient. It's not clotted, but, and this video is not playing particularly well, but you can see the blood sort of swirling around just in B mode there. If you compress the vessels here, you'll see that it's easily compressed, and sometimes it's just with the higher resolution equipment that we've got these days, you can see that B mode flow without even turning the Doppler on. Then it's a case of choosing your right vessel, or choosing the easiest vessel. You want the biggest target, and also the target that has got less danger lurking. So in this example, again, the radial artery with the radial veins, the vena comitantes here, the paired veins either side. Yes, I could go for one of these tiny veins here, but there's this big superficial vein over here that's much bigger, much easier to put a catheter in, and is further away from the artery, so poses less risk. And I've just outlined these here. So we've got the artery in red, obviously, the paired radial veins here, and a superficial vessel here. I know that the big green one is a vein. You can see it compress, and you can also see the veins here winking on either side of the artery. Once you've found and chosen your target, you want to map the vessel. So just track the vein up and down, whether you're in the neck or whether you're in the arm or the leg. Just track the vein up and down, 5 centimeters each way. You want to know where it's actually lying and that it doesn't branch unexpectedly or suddenly veer off path. Like the jugular vein, doing that technique blind, you want to aim sort of a little bit medially, or but sometimes those vessels can sit quite straight, or as you track up and down the vein, you find some clot or something. So it's a good idea to, once you've chosen your target, just track it up and down the arm or the leg, the neck, to follow the path so that you know that it's lying straight, and you've got a good idea in your mind where this vessel actually goes. Of course, you need to check the patency. You don't want to get any surprising clots along the way, so it's just a bit of a push. And you can see here those veins winking at you, which tells me that they're patent. Here's an example of an internal jugular vein that is not patent. As they compress here, there's absolutely no flow in that, and there's a big clot, not the ideal spot to put a cannula. This is a clot in superficial vein. And we have, this is subclavian vein. So you can see this one partially sort of squishes, but there's still, so it's a little bit patent, not completely occluded, but it does have some clot in there. Now the next step is to measure the size of your vessel. When you're choosing a cannula, the cannula or whatever tube you're putting into that should only occupy about half the size of the vessel. And I think from memory, someone said, you know, a 3 millimeter vessel is a 3 gauge cannula or 3 French cannula. Anyway, you would understand the sizings better. But once you know how big the vessel is, you know what size cannula you can actually effectively fit in there. And you don't want the cannula to completely fill the vessel because that's going to pose problems for blocking it off. So you want the cannula to be about half the size of the diameter of the vessel. Now, when you're measuring the diameter of the vessel, you've just got to have a really light feather touch so that you're not accidentally compressing it. You know, I guess is try to measure this without the tourniquet on because it's sort of the natural state, but you can certainly put the tourniquet on to help dilate it to get access and make that target bigger once you get going. The other thing to think about is what's the depth of the vessel. If I know how deep the vessel is, I can apply the Pythagoras' theorem to figure out how long does my cannula need to be able to get into the vessel. Now we want to try to make sure that we've still got 40–50% of the cannula outside the body so that you can affix it. You don't want the needle buried up to the hilt like it is in this example here, and still not quite be in the middle of the vessel, because then it's easy that it can slip out and stuff. So if I know how deep the vessel is, I can then move my needle that far away from the probe, and then using a 45-degree angle, it'll be 1 to 1 here, and then it's 1 and 1.4 times on the other side. So I can figure out how long a cannula or needle I need to get into the target, but also if I just wanted that static sort of approach, how far back from the probe I need to be at a 45-degree angle to get the needle tip in the vein. Now the next sort of problem that I see commonly that does affect the success of a procedure is poor setup of your equipment. The biggest tip here is to hold your probe down low. If you're holding your probe right up the top because you don't want to get your hands dirty or whatever, it's going to slip. You have no control over it. It's like trying to write using your pen and just holding the end of the pen and then trying to make something legible. It just doesn't work. So you need to have fingertip control over the probe and hold your probe quite low down with your 4th and 5th finger stabilizing your hand position and resting on the patient. The gel is slippery too, so that's going to help things all slide all over the place. So having your hand anchored on the patient is really important. The other thing to think about when you're setting yourself up, we have an example here standing up where you're kind of looking down on it. Now, if you're looking down, chances are you're going to put pressure on the vessel because you're leaning a little bit, versus being able to sit down and stabilize your forearms as well. If you stabilize your forearm position as well, it means that you can have a much lighter touch with the probe, but just everything is much more steady. There's less slip, and the probe position is held in a real steady position. So make sure you either bring the bed up or whatever it needs to be, you get a chair, but try to stabilize your hand position because that will help you get better access. The other thing to think about is which hand. So you should be injecting or putting the needle in with your dominant hand, but often in the scout scan phase of things, you scan with your dominant hand. By the time we get to actually putting the needle in, all you want your non-dominant hand to do is just to hold everything still. So figure out where everything is and scan with your dominant hand, and then just hold the probe still with your other hand. And you need to practice that so that it's not the first time when you get to a patient. But I don't know, I'm pretty cack-handed with my non-dominant hand, and it's really, unless you practice it all the time, it's really hard to be able to do the scan well with your non-dominant hand. So At the scout scan phase, use your preferred hand. By the time we get to inject, just hold the probe still and in place with your non-dominant hand so that you're injecting with your dominant hand. The other thing is to make sure everything's lined up. Now, I did this myself one time. We had a course and a couple of ladies on our course were like, no, you have a go, Suean. So the very first time I ever put a needle, and I've only done it once on a live person anyway. I've done it more on some cadavers, but the only time was in front of a course full of 12 people. And it was interesting because one of the candidates in our course, she lay down, she said, here, do my, I put a cannula in my basilic. And of course I did everything wrong that I'm telling you not to do wrong. And she pointed this out. And then when I did take the time to line up and get the arm out properly and get the machine in the right place, it was rather easy. Bit weird because I'd never done it before, but making sure that everything is positioned well. Your machine is in front of you, so you want your knees and your eyes and your hips all pointing in the same direction. So in this instance, having the machine on the other side of the bed would increase the chances of success here. And this positioning, not only is it just awkward and not so ergonomic, but it has to be challenging spatially to figure out which side everything's coming from when everything's back to front. So here's an example of the machine in a much better position. So, you know, the needle going in the direction that you're looking and making sure that the machine is across the other side from you and in your line of sight nice and easily. Another tip is to use a drip stand to support the weight of the probe. Once you have your field all sterile, you know, you don't want your probe falling off on the ground and all the rest of it. Also, the weight of the cord can sort of drag you ever so subtly off your target. So if you just suspend the cord over the drip stand, it takes the weight of the cord, but also means that when you need to put things down to pick it all up, everything's there ready to go quite easily again. Now we get to performing the procedure. There's all sorts of different probe covers. Some advocate for, it depends how sterile, but there are some guidelines and National Health Standard guidelines that sort of talk about what level of protection is required, and pretty much for anything where there's going to be any bodily fluids, it's high level disinfection, and there should be sterile probe covers. So, you know, there's lots of different versions of this. There's freezer bags, like sterile freezer bags, or specifically made probe covers that are manufacturer specific. So, you know, Sonosite has their version, Philips has their version, and GE has theirs, and it fits those probes exactly. The different probe covers depends on what you like and what your hospital actually gets. But some of them are much easier and more friendly to use. Some of them a bit clunky and big and make it harder to perform the procedure. But whatever you're doing, you need to make sure as you prepare your probe cover, make sure it's all nice and tight. There's no air gaps along the top here, and there's not a whole heap of loose bag here that you can accidentally put your needle through. A couple of points to think about just before we get into the different techniques. The size of your needle will dictate how easy it is to see. So the bigger the interface is that interferes with the ultrasound exam, the easier that needle is to see. There's all sorts of techniques. There's echogenic needle tips. There's, you know, beam steering, needle guided stuff on the machines. It's all good, but none of that's going to help you if you don't have a good technique to start with. And a lot of them cost quite a lot. I've seen some of those echogenic needle tips that are about $10 a pop, and it doesn't compensate for poor technique. You still have to make sure you get your needle in the path of the ultrasound machine, or ultrasound beam. So, you know, this is the difference between a 21 gauge needle and an 18 gauge needle. It's subtle, but you can see that the bigger the needle, the easier they are to see on the ultrasound. Just an explanation here, or a reminder really, of in plane and out of plane. So we look at the plane of the ultrasound being the length of it. So if we're coming out of plane, we're coming at 90 degrees to the ultrasound plane and we see the needle tip. Whereas when we're in plane, we get reflection from the whole surface of the needle. When we talk about these and describe these different techniques, we talk about in and out of plane, referring to the plane of the needle takes with regard to the ultrasound beam. And then we talk about the short axis and the long axis of the anatomy. So let's look at the out of plane approach. We've got one here. The out of plane approach, if you play follow the leader or walk the probe, so you line everything up to start with, you put your target in the middle, you put your needle in the middle of the ultrasound beam, and the newer probes are all marked on the ends and at the side. So put your target in the middle, put your needle in the middle, everything should be lined up. Advance your needle a little bit, see the tip, then move the probe away so that you can't see anything, and then advance the needle and then the probe, and keep following the leader. The probe is the leader until you get into the vessel. So the reason for doing this is when the needle is out of plane, it will be echogenic anywhere along that path. And you want to make sure you have the tip, and not that you've advanced the tip well past your target and that you're looking at the shaft of the needle. So we need to advance the probe in front of where the tip is so that we see that tip come into view and we know it's the tip of the needle and not the shaft of the needle. So I was explaining then, you've got your probe here, and I don't know if you can appreciate, but there's a tiny center mark here. You want to put your needle in the middle of the probe, and your needle should show up in the middle here. When you're out of alignment, so this side, we're on the probe marker side here, so you can see the probe marker just here, and that corresponds to the probe marker here. So we can see our needle tip coming in at the side here, and when we're out of alignment on the other side, it shows up on the other side of the field of view. So you can figure out which way, you know, if your needle is going not quite where you want it, you can figure out where's my probe marker and the screen marker, and you can reposition or redirect your needle so that it ends up towards your target more. The next step is to make sure you center the anatomy, or center the anatomy first and then center the needle. So if we've got the blue dot here being the vessel and we line everything up, we should have our vessel in the middle and our needle appearing in the middle. If we have our target anatomy in the middle, but our needle's not quite in the middle, you'll see the needle tip miss the target. It is possible to not be aligned, so you line your needle tip up with this is harder to do, but it's possible, to deliberately malalign your target and then put the needle at the same degree of malalignment and you'll get into the vessel. So it's much easier though if you put your target in the middle and then your needle goes in the middle of the probe, and then everything's all plumb and makes it much easier for a successful procedure. Another cheats way to figure out where the middle is, if you just pop the M mode, activate the M mode, and it'll bring up the M line cursor. If you haven't bumped anything, usually that will come up in the middle of the screen, and you can use that as a guide to sort of get your anatomy in the middle of the screen. If you can't see the needle tip, it may be that you need to slide up and down the neck to find where the tip is, or to tilt your probe towards your needle tip to find the end of the needle. We'll quickly look at the in-plane approach. Here's an example of it. So we see the whole length of the needle coming in to the target vessel. When we're going in plane, the more horizontal our needle is, the better specular reflection we get from that. The ideal angle's at 45 degrees. We still get quite a nice reflection. And the steeper we go, the harder it is for us to see the needle, although in the Phantom it works quite nicely. But in real anatomy, and I couldn't find a volunteer for that today, funnily enough. In real anatomy, you know, that really steep needle angle means that we won't visualize the needle as well. You can use beam steering, which is essentially steering the ultrasound beam one way or the other so that it makes it more perpendicular with your target, and that can enhance the visualization of the needle. But yeah, you need to find where that button is and if you have that feature on your machine. Remember that the ultrasound beam thickness is about the slice of a credit card. Now this is what, way back when we first started teaching, and I'd never put a needle into anything, and we got our first Phantom. And I was so excited and I took it along to work. And what absolutely surprised me, after many years of poo-pooing radiologists who could never get the needle in the right thing, I'd be sitting there holding my probe so slowly, so still, and getting frustrated. But what absolutely surprised me was how thin the ultrasound beam is. We kind of look at the footprint of the probe and we think, you know, it's not that wide, but you think it's wider than it actually is. And it's really very thin. And to be able to see the needle the whole way along, you've kind of got to thread your needle along the length of this credit card the whole way along. So if we look at a needle on the end of the probe, when it's right in the middle, we see a good reflection. I can be just off center a little bit and I'll get absolutely nothing, absolutely nothing. In real tissue, if you're off just a little bit, sometimes you'll see a little bit of movement of the tissue planes as your needle comes in. But if you are off axis, you won't see the needle at all. And if we're a little bit oblique, and I've exaggerated it here, but you only see the needle where it intersects the ultrasound beam. And this last example here is probably the most common problem I see people having, insofar as they're not lined up exactly. You know, you're kind of behind, but there's a bit of parallax error and you're a little tiny bit oblique at the entry point, and by the time you get to your target, it's well and truly off skew. So here's an example of that. If you are just a tiny, tiny little bit off, and it could even be a smaller degree than this really, but I've exaggerated a little bit here, that will mean you won't be able to see your needle. You have to make sure you get right in behind and make sure everything's lined up. So taking that extra 20 seconds to take a bigger breath and to line up exactly means that you're going to get better success rates, especially for that in-plane approach. It's kind of like shooting archery, you know, a little bit of, to get the bullseye, you have to be right, lined up exactly right. Just a tiny little bit off means that by the time you get to your target, you're well off skew. This is another way to demonstrate, you know, if once you've got your needle in place, if you can't see the needle in the longitudinal plane, slide left and right. If you've lined up straight, sliding left and right should find your needle plane. And if you're a little bit off, you either rotate and then slide. But the problem occurs when your anatomy is sitting over here. So typically in an in-plane approach, you should find your target, and that's the lineup of your probe, and then your probe doesn't move. You have to put your needle into the path of the ultrasound beam. You know, once you start getting the needle in, if you've gone off, if you've gone crooked, it's not going to help. So it's, you know, pull out, start again, line up the anatomy, get your vessel or your target in view, keep your probe very still, and then you put your needle into the path of the ultrasound beam. So here's that in-plane approach again. Now the thing about vascular access is that, or any procedure to be honest, is we're not in a conventional imaging setup now. Because you need to position your equipment so that it's in front of you, that might mean that, you know, top and bottom is all back to front now. So for example, if we're doing central access, if you come in from the head of the patient and you have your machine in front of you, the left and right and the orientation of the image is now not necessarily left and right like it is when you're scanning other parts of the body. So you need to be very mindful about where your probe marker is and make sure wherever your machine is and however you're set up that your probe marker and your screen marker are on the same side. Now the reason for this is if you put your needle in on the side of the probe marker, you'll see it come in this way. If you put your needle in from the other side, it'll come in from the non-probe marker side of the screen. Now, I have seen on occasion people intently watching the left-hand side of the screen, waiting for their needle, and they've advanced their needle coming in from the right side of the screen because their probe's back to front or whatever, and they're actually in, and they're like, yeah, you've got vascular access, but it's not ultrasound guided. And the challenge here, I think, for anyone, especially if you've learned a blind approach to start with, is taking that leap of faith that is now looking at, you know, getting your needle into plane, looking at your patient to line everything up, and then trusting yourself to just watch the monitor and guide your progress with the ultrasound. It's a big jump to take, and it's kind of counterintuitive because you're used to putting needles in and watching where you're going on the patient. So being mindful of where your probe markers are and how you're set up is really important. Here's an example where we've just come in from the non-probe marker side, and that's all good and well if you're expecting the needle to come in from that side. But if you're looking so focused and intently on the left-hand side of the screen, you might miss that. So just be mindful of where your probe marker and screen marker are and put them all on the same side. Now this is an example of one that I just did today, and you can see that it's not quite in plane, but I have got the tip. So I've come in a little bit obliquely as indicated in this diagram here. And if we just slide left and right here, you'd find the needle tip a little bit better. And to get that specular reflection the whole way along, I'd have to rotate. So there's hopefully some useful tips and tricks if you haven't tried some of them already. But what we've looked at is being prepared and doing a good scout scan before you get scrubbed, making sure when you are that you set your equipment up so that everything's lined up. You want your eyes and your knees and your hips pointing in the same direction as you inject, that you can see the screen, and to have your patient positioning so that everything's lined up and you're not coming in, you know, crooked or on the side somehow. And then when you're lining up and looking for your needle, to be mindful in an in-plane approach, which is more difficult, I think, but once you get the hang of it is not so bad. In an in-plane approach, it's like there's a credit card coming out as the ultrasound beam, and you've got to thread your needle along the whole length of the credit card. And the out-of-plane approach, follow the leader, line everything up again, put your target in the middle, put your needle in the middle of the probe, and hopefully that means you'll get success more often on the first time. Does anyone have any questions?
Suean, I think that was great. I'm not sure I have a question as such. Just to have a quick comment, and I see Alan's online too, so I know he does lots of these ultrasound-guided peripheral IV cannulas. One comment I would make is this is actually kind of hard to do. It's actually hard for interns to learn this compared to some other applications, I think, of point-of-care ultrasound. I mean, I think it's easier to put in a central line than it is to put in a peripheral IV cannula. But the cool thing is, like you mentioned, is once you get good at this technique, it extrapolates so well to other things like arthrocentesis, localizing foreign bodies, doing nerve blocks. I don't know, Alan, would you agree with that? I think you're on mute there, Alan. Yep. Sorry.
Yeah. Yeah. I mean, I'm not embarrassed to admit I still find this one of the more challenging things to do with ultrasound. I'm more of a diagnostic person because I find the procedures challenging, especially real-time procedures. I suppose probably Brian's the same as me. I grew up in the age where we didn't have an ultrasound, so we're used to doing the procedures blindly, even central lines. But certainly, you know, the arthrocentesis, for instance, blindly. And, you know, so I suppose I'm more naturally gravitated, apart from this damn dog, I naturally gravitated to more the X marks the spot or the static or assisted technique because, you know, it felt more comfortable to me having been used to a blind technique. And also I had both hands available to me, and I had, you know, I sort of, I generally, and I know I'm a bit old fashioned because I know the younger people who play plenty of video games, That's the thing. They're so good spatially as well. You know, they love the real-time technique, and I'm a bit old-fashioned, and I prefer the static X marks the spot technique. I find it less finicky. I don't have to worry quite so infinitely about the sterility of the procedure. I've got both hands available to do the procedure as well. So I think my personal practice is, if it's a biggish target, it's not going to move around a lot, I still do the bit more old-fashioned static assisted X marks the spot technique. But having used the ultrasound to make sure I know, you know, how far it's in, what angle I've got to approach it, making sure there's nothing else around it. Still doing that. You know, I'm obviously scouting because I'm X marking the spots based on what I see. And I had a patient the other night. I could not get a real-time peripheral IV, and I wish the Phantom. I wish the people were as easy to cannulate as the Phantoms, because this patient, she was elderly, she was large, and every time I tried to advance the cannula, the whole tissue was moving around continuously. And then also, even though there was a tourniquet on, it was still squashing down. And you know, obviously having done diagnostic, I can do light touch, but despite light touch, every time you advance the cannula, the actual vein or the target was squashing down visually as well. And I just could not get it. And I still find it frustrating because, as you say, you know, the larger targets, the central veins, I'm quite happy to do in real time. I have not mastered the peripheral vein cannulation with ultrasound guided at the moment. And I'm probably still a bit getting used to the nerve blocks as well. Yeah, so I'm a bit old fashioned in that way, and I want to get better at real time, but I find it very difficult.
Yeah, fair enough, Alan. I think lots of people, there's a definitely learning curve, and having taught this to a lot of the junior staff, and some of them take it really easy, and some are just honestly a bit hopeless to begin with.
Do you, when you do peripherals, Alan, are you going more close to the wrist, or do you come up the arm a little bit?
Well, I mean, you know, partly you got to obviously, you know, I think we've got to be always got to frame it by saying, please don't grab the ultrasound for every single peripheral IV cannulation you want to do, because that would be totally inappropriate, and that would be slowing down things. Because in the patient that, you know, you can see the vein or feel the vein. If you're not an intern, you should be able to get it nearly all the time, especially someone who's been doing it for 20 or 25 years. And then you need the ultrasound for other things that are more important. So I suppose the counter argument to that is, if you don't do it on the easy people, then when you have a harder person, you're going to struggle. But there is that bit of tension. Yeah. So, but I don't want to give the message, and I always tell people, it's not grab the ultrasound for every single IV cannulation. And so I have the advantage that a lot of the interns and junior doctors don't, that, you know, I can get it blindly, you know, probably about 95% of the time without too much effort. But as you exactly said at the start of the presentation, there are those categories that you know are going to be extremely difficult. It doesn't matter if you've been doing it for 25 years, you're still not going to get it without the ultrasound.
It's interesting, the literature talks about, you know, 40 to 50 cases before you start to develop some sort of proficiency at this. And certainly, whether it be musculoskeletal injections or nerve blocks, people anecdotally have said similar sort of numbers. I'm wondering, on your patient where it's jumping around, if you come up the arm a little bit, it's still probably, there's a little bit more muscle tissue, depends on how old they are, I guess, but a little bit more muscle tissue that can help sort of stabilize, and it's a little bit deeper. So it might be a little bit easier.
I was in the cubital fossa.
Oh, yeah.
And it was still moving around.
Gosh.
Yeah.
Yes, the thing is, the patients move, but the phantoms don't.
And the patient moves as well, but the patient wasn't moving. It's just the tissue was moving. But as you just said, then, you know, adding patient
phantoms are a bit stickier too. The rubber or whatever that they're made of is much more grippy than real people's tissue.
One trick that I know a lot of my colleagues do, and I probably don't as much, is they'll often use a little bit of lignocaine in the skin before they actually inject. That ensures the patient doesn't jump around as much, and it's just a nicer thing to do probably. One word of caution, however, is make sure all the air is out of your lignocaine before you inject it, because I've had that disaster happen to me before. I don't know what are the other experiences on the chat.
Yeah, I'm same.
Rajesh is saying he always uses lignocaine.
Good for him. He's
Yeah.
much better than I am. That's for sure.
Are there
Well,
any other?
I wish we had a choice of cannula. Like it took us ages just to get one size long cannula, which is
Yes.
we've got 20s. We don't have a range, and I you know, it's sort of, you know, I didn't think about your point about the size of the diameter of the vessel and therefore what size cannula you can get into it, but that works when you've got a choice of cannula. Unfortunately, we don't.
But it's funny, yeah. So the longer the cannula, the better off you are. And there's a little bit on the chat about that. And there's some literature coming out now looking at sort of midlines or 10 centimeter-ish long lines. The bottom line is the more the cannula you actually have in the vein, the less likely they're to blow. So certainly in my emergency department, we have the 18 and 20 gauge 48 millimeter long cannulas, which I encourage everybody to use. Nothing worse than doing such a great job getting a standard cannula into a vein and then realizing it blows, because obviously when you're cannulating with ultrasound, you're often taking a longer distance to actually get to the vessel. And so encouraging people to use those longer cannulas.
Yeah. Are there any other tips that anyone has found when they've been doing this that they'd like to share?
I use the single-use sterile gel packets generally for my peripheral ultrasound guided cannulas. And you mentioned a probe cover plus high-level disinfection, which I don't know any emergency department, honestly, that's doing high-level disinfection after they put a cannula in.
Well,
Maybe there's a couple out there. But suffice to say that ASEM, the Australasian College for Emergency Medicine, and certainly the Americans advocate just for a probe cover and low-level disinfection. I don't know. That's not really a tip, I guess. It's more controversy than anything else.
yeah, I think it is controversial. The ASUM guidelines came out, and I've just been reading them this week. And pretty much, if it's intact skin, then you can just do low-level disinfection. But anything that's vaguely looking like there's either broken skin or any mucus or blood product or anything should be probe covers and high-level disinfection.
That's what they say, yes. Any kind of needling, high level. That, suffice to say, nobody's doing it. Well, I'd be pleasantly surprised to find emergency departments in Australia that are doing that.
Yeah.
But,
do you find with the sterile gel that messes up your field at all, Brian?
I use it judiciously. I mean, the reality is you don't necessarily even have to use gel at all. You could just use chlorhexidine, any kind of anything to get the air out of the way. I'm not sure. I personally use it, but sparingly. I'm not sure what Alan's experience is.
Hi, Suean.
Yeah.
Hello.
Oh.
Nice to see you after, it's been a while.
Yes, I can't see you.
Just a quick one about, we have started using probe covers at least for elective ones, like where we have time. We're encouraging that at least, even if there's no broken skin or whatever. It's just like getting on to more kind of better aseptic kind of field. The crash ones, the recess ones, obviously, I mean, sometimes you just can't do much, but we've kind of moved over to using more and more probe covers for just even for peripheral cannulations. Sort of,
We've got the cheap freezer bags, which are $1 each, which you can just they're easily, you can buy them in Australia pretty easily.
Days, there's so much of competition that the ones which were like kind of $2-3 before have come down as well. There's a lot.
Yep.
I remember 10 years back, we used to use that same freezer bag kind of thing, whereas the ICU, because they always had enough funding, they were using those really fancy ones. But there's so much of competition now. They're quite cheap now these days. So
I think if you're putting in a central line, you want to have more adherence to sterility, and I would use the proper big pull-ups type probe cover. But for just a simple peripheral, I'll just use a freezer bag. But I don't think there's any right answer on that.
We used to use the opside once upon a time, but apparently there's now issues with opsides because the footprint gets destroyed. Like it's actually, when you peel off the opside, the actual footprint does sort of get affected, and over a period, actually the life is sort of shortened. So I think there was some literature on that a few years back. Yeah,
just on the sterile gel thing, you can, like chlorhexidine will dry very quickly, but a little bit of betadine will hang around a bit, and even just some saline, anything that just eliminates the gap. So I know sometimes if you get too carried away with too much gel, then you've got a whole heap of gel in your field and you've got to clean that off before you can put your needle in. So depends what's available and what it all costs and how that factors into what's, you know, who buys what bits for your department.
I tend to use Surgi Lube, not that it's ideal, but
I do the same, Alan. Yeah, the KY jelly.
yeah.
Yeah, I do too. Yeah.
Handy, and it's easy to just sort of. One thing quickly, Suean, I remember like years back, there was something in the literature about when you were doing central lines, especially the big ones, the jugglers. There were issues like people using a lot of gel and then introduction of gel in the vein. There was some kind of complications, some issues about that. I can't remember. There's like years back, I remember reading something about that.
Yeah, I can't say that I've seen that particular article, but I know we did some training with the, what are they called? Orthopedic surgeon in Malaysia. And he was big on the don't use gel, because he found that if you did get a little bit of gel in the wound, that it made it bleed more on people who had problems. But it was, you know, anecdotal. I don't know if he had it written up. But he was certainly saying, yeah, don't use gel because it actually makes it a messier wound. So I can't remember any articles per se, but it wouldn't surprise. I mean, wouldn't want to get gel in there.
Yeah, it's
Hey,
just,
Suean, can I ask you a question?
Yeah.
You do a lot of obviously teaching at Zedu, and about question about models or phantoms, excuse me. Do you just generally tend to use the blue phantom models, or have you found other models that you've met with success, whether it be chicken or your own gelatin models? I'm just curious what
So, it's interesting. We have on our website a Phantom Compendium page, which has got, I don't know, 90 different published references of how to make a phantom for just about anything, whether it's, you know, the pleurocentesis thing with the rack of ribs. And I have discovered that I am absolutely rubbish with gelatin. I can make you a really nice pavlova and lots of other things, but I cannot cook with gelatin for love nor money. So the few times that I've tried I think it's injectable orange has got a recipe for like Metamucil and gelatin. They degrade really quickly. So we don't use those in our courses simply for the fact that the preparation time and how quickly they degrade and how you need to store them, like either put them in the fridge or whatever, because we took it to a conference one time and it sweats and it was just like jelly falling apart and was very messy. If I have to really quickly, tofu, I've used tofu. In Malaysia, we use tofu, but tofu in Malaysia is much, much cheaper, and you can get different grades of tofu, like really soft, like jelly stuff, and then firmer stuff. So what I saw was we used a big block, and on the other side of it, put a knife in and buried a vitamin E capsule, turned it the other way and went in, and that was pretty good. I think my favorite's just if you're making them, is the chicken breast, where you get one of those balloons that, you know, they make the things for the kids, balloon art, fill that up with water and then wrap a chicken breast around it. The chicken breast tissue is very similar to muscle tissue. So if you wrap the chicken breast around the balloon and then wrap that in cling wrap, put a bit of gel on the chicken breast and wrap it in cling wrap so there's no air gaps. We often use in our, like for foreign bodies and stuff, we'll use a leg of turkey or a leg of a lamb or whatever meat we can get cheaply, and shove some things in for that, which is fine. And only one time we tried reusing it and it stunk so bad. So you have to use it that day and then chuck it. It was just revolting.
The difficulty with the food items, Suean, is in the public hospital setting. What we've experienced is infection control. People just won't let you use any animal products. Yeah. Even if you wrap it in Glad wrap, they still won't let you use it. I did some volunteer workshops on Saturday mornings for Monash Uni students, and I didn't, luckily I didn't have to do preparation. They were motivated, and so they did some gelatin phantoms, and we had 15 to 20 in a workshop with 4 stations, so we got about 4 to 5 people through on the same phantom before it was beyond salvaging and useful.
Yeah.
But I agree with you. You know, if you had more people than that rotating through the phantom, it just won't last. I mean, the blue phantoms, the problem is they're just bloody expensive.
Yeah.
There's blue phantoms, the little blue blocks, by the time you get them in Australian dollars, they're $800 to $1,000. Now that's, some of ours are, a good few years old, because we have a few of them that we rotate, and we're absolutely vigilant about 2 or 3 needle passes. So you have to use a sharp needle, and vigilant about caring for them properly, making sure they're filled up and all the rest of it. But the blue phantom, the rubber or whatever it is, the gel stuff that makes the phantom, 10 years ago, we bought a central access line, and it lasted. I reckon it was way more than 1,500 pokes, that it just went on and on for years. But the newer ones, as soon as you get the phantom, you put a needle in, you've got a track mark, and then that looks as good as the needle, and you can't tell which is your needle and which is your track mark. So I've been, in recent times, we probably haven't bought a new one for a couple of years, but in recent times I've been a little bit disappointed with them, because they are very, very expensive, and also, the track mark. So there's a couple of other options, Limbs and Things or Kyoto Kagaku. They do, I think Limbs and Things stocks the Kyoto Kagaku phantoms. And
I'm trying to spell that, Sue. I'm writing this down.
Kyoto, Kyoto, like the city, and
yeah.
Kagaku is Kagaku.
Yeah, okay.
And I think the distributor in Australia is Limbs and Things, and we've also there's a new company that we're going to be getting some of them in. It's like ballistics gel, and it comes in a kit, and you can melt them 3 or 4 times. I think 3 times is the instruction. So you can.
I saw that at a conference at AIUM a couple of years ago. Yeah, they looked interesting.
They get as many sticks out of one melting as what the blue phantoms do. So we've got some of those. I brought home some from the last AIUM conference, and they work really nicely. So, and the other thing with the ballistics gel, like from the same company, you can just buy a block of ballistics gel and then make it into whatever shape you like. The ballistics gel feels like the blue phantom rubber, but you can melt it down and reuse it.
Yeah.
Amazing what people are doing, isn't it? Yeah.
I got 3 blue phantoms myself, and the problem is when you're running sort of workshops, especially in a hospital setting, they want to give you their old cannulas, again, to save money. And then they're all safety cannulas these days, so they've got the air chamber in them. So every time you're sticking the cannula in there, you're forcing air in. And but I didn't realize, and it was deteriorating, not just the track marks, but I couldn't even see the vessels because of all this reverberation artifact. And then I only realized after watching some stuff that David Canty did from the University of Melbourne that if you put a light behind them and you tip them upside down, you can make the air rise, and then you can suck the air out with a syringe. And I got food dye and water, and I just put more liquid in. So I actually managed to salvage them. It doesn't get rid of the track mark problem, but it got rid of the air and the vessels problem, which was ruining them as well.
Well, we go through that process of sucking out the air, and you can stand them on the end and put your needle down you can see one end where the holes are, and you can put your needle down and suck out the air. But sometimes you get little micro bubbles that sort of sit on the very surface. So we have to just guide the needle in and suck that out. The blue phantom ones, theoretically, are supposed to have the solution that they provide. And because I've asked about this insofar as, well, can I just use food colouring? And that's the cheap way. But the solution that they provide has got some antimicrobial agents in them, and it does feel a little bit soapy. So there is something about it, because we've had somewhere we've put water in and they do grow stuff. It grows lovely clots.
Yes, but I got a DVT in one of mine from putting water in it, and from now on I have to use their proprietary stuff.
Yeah.
Yeah.
But yeah, the ballistics gel is way cheaper than the Blue Phantom stuff. I think it's like, I don't know, $200 versus $600, and you can melt them and redo them again.
And Suean, you said a lot of this stuff is on your website. You have a whole page sort of dedicated to.
On our website, I'm just thinking because it's new, I think it's under resources. We've got like the medical education or foam ed resources there that's got lots of anything free online access, medical ultrasound stuff. So, the Mike Mellon and Matt Dawson bedside emergency ultrasound books, there's all that sort of stuff. And then there's a separate page that's Phantom Compendium.
Okay.
I could probably bring it up here and show you if you like.
It's amazing. It's amazing what people have been advocating. One of the more interesting things I heard was to simulate purulence in an ultrasound Phantom. You mix up mayonnaise and maple syrup, which just doesn't do it for me. I'm not. Yeah.
There's I was speaking at a medical students conference in Graz, and there was one of the students there, and it's a necessity thing, They were getting frustrated with the reusability of stuff, and so she had injected a little bit of, and there's a recipe for it, but she put a little bit of alcohol or something into it, which helped kill the bugs and made it last longer. So and had this apple cord, some sort of apple core thing, and then it was just the block of gel that sat in a bath of water that she'd done an apple core out of the middle, and it worked really, really well. It was there's lots of very inventive people. I'm just trying to share my screen here. Has that got green on it? Yeah, right. So under resources, you'll find that's where you've got the back issues of the Coaching Corner. There's a whole heap of compiled COVID resources, ultrasound apps, and then under the Phantom Compendium.
Oh, cool.
Yeah, so that's got this is probably one of our most popular websites, and it's funny, I've been in the audience at conferences in America and seen this come up and thought, oh, look at that. So well used. So it's foreign body phantoms, biliary phantoms, biopsy, breast, cardiac,
wow,
endo, anal and rectal, if that's what takes your fancy, gynae. And a lot of them have either a video that shows you how to do it. Lung phantoms, I think James Rippey's he's got this fancy one where you can drill your rack of ribs onto a rubbish bin.
Yeah, I can't remember what the skin was, but I remember in a lung phantom I read in a Journal of Ultrasound and Medicine article they used a soaked sponge.
Yes.
A sponge full of fluid.
One of those soaked sponge, and even with the green scour bit on, in just a Ziploc bag with some water in it, and then some gel on the top. It looks like a lung.
Mm.
So there's all those ones, and also under resources here. There's the ebooks and stuff, and the lectures from the SONOWAS conference that we held a couple of years ago. So a treasure trove of free resources for you there.
Cool. I'll have to have a look.
There you go. Did anyone else have any other comments or questions or ideas for our next session?
What do you have planned for next session?
Well, right at this minute, nothing. I'm open to
You've got a month to think about it. Yeah.
Yeah, I'm open to suggestions. So I usually kind of start sweating on it about a week out and coming up with the idea. So if you've got any ideas, certainly send them to me via email or on Twitter, or give me a call, whatever works. Alrighty then. Well, thank you all so much for coming along tonight. It's nice to see your faces, or hear your voice at least. It's that contact with the outside world. It's good.
Thanks, Suean.
Thanks, Anne.
Thanks,
Thank
Suean. Always
you.
enjoy it. See you the next
All
time.
right, well, see you next time.
Thanks, Suean.
Thanks.
Thanks, Suean.
See ya.